start with some good news. In terms of the overall capacity of the hospital, we are, this morning we started at 276 patients. As you know, we have 330 licensed beds, and so we continue to be very full. We have a total of 105 patients that have been diagnosed with COVID that are admitted to the hospital. 33 of them are in critical care, and 14 patients are on vents. So our vented patients are down a little bit, which is a nice relief for everybody, but the overall numbers are still pretty high. And I'm sure that Dr. Scoggins will talk a little bit about the progression of patients. So although we do kind of ebb and flow, we still have a very high number, and of course they can get sicker pretty quick on us. We maintain patients in our Health Resource Center, which is our classroom, which we've changed the name to our COVID Recovery Unit. This morning they had 9 patients, and we continue to need to use that space because of the high number of COVID patients that we have. And we continue also to care for COVID and non-COVID patients in non-traditional areas. We continue to overflow into our post-anesthesia care unit for critical care patients, as well as for our intermediate care patients that we're overflowing into our heart center. So it has taken a lot of work to make sure that we can care for every patient that comes to our doors and be able to care for them safely. Dr. Scoggins?
Thank you, Joan. So I'll just kind of give a medical update on the ICU and the hospital in general. I think the patient numbers are still very high for COVID in the hospital, also very sick. We've been averaging about 30 or so ICU patients a day. Many of those, as Joan said, intubated on ventilators. We still have very little ability to transfer patients out of as all the hospitals in the region are full, and our critical access hospitals are also limited in what they can transfer to other facilities. We have been able to accept some of the patients from our critical access hospitals in the region this week. Part of that's due to changes that we made with the crisis standards of care and being able to take care of more patients. And it's allowed us to utilize our nursing more efficiently and our beds more efficiently. The DOD physicians, nurses, and respiratory therapists have been integrated into our care team, and it's been great having them here. They've been helping us quite a bit in caring for these very sick patients, and we're beginning to get more resources in as well, federally sourced resources, which has also helped us increase our ability to take more patients. I think that again, the surprising thing is how many patients we still are seeing on a daily basis. We're bringing in probably 10 to 15 new admissions for COVID a day, and we've done a lot of things trying to discharge patients and to keep the patients from coming into the hospital that have been successful, such as the monoclonal antibody clinic here at Kootenai, and I'm not sure the status of the one that was being set up by Heritage Health, but I know that they were supposed to be opening in the next day or so. We've also been able to set up patients who are low acuity with home oxygen, which has also kept the numbers of admissions down to the hospital, and that's been pretty successful. We arranged for a follow-up with by telemedicine with some of our physicians here. So I think that overall we've been managing the situation well. It's still, I think, surprising the number of patients that we're seeing, especially the number of unvaccinated patients that are coming in to the facility. I'll let Emily talk. And
awesome. And Emily, can you just say your last name for me?
Yes. So I'm Emily Farness, and I've been a nurse at Kootenai for 7 years, 3 in the ICU, and I'm also on the rapid response team. And I was just asked to kind of give some insight into what it's like in the ICU for nursing staff. I work for one of the largest departments in the hospital, and we've been at this for over a year now, so it's hard to summarize all of those experiences, but a few thoughts I had were, at this point in the pandemic, we're actually fairly well practiced in the care of COVID patients. We know what to watch for. Our practices have evolved as new research and evidence has come out to support change and updates, and I think the nursing staff and physician staff and respiratory therapists feel confident that we're caring for these patients to the best of our ability. And as nurses, a lot of our care has expanded to supporting these patients' emotional needs as they're isolated from family and friends and church support, school support, all of those communities. And that takes a huge toll on our patients, and it also takes a huge toll on the staff to kind of go above and beyond in that way. We're fairly practiced in those things, and that's becoming a pretty normal workflow for us. Something that's not normal with this Delta wave is seeing younger and otherwise healthier patients. It's strange to see patients that are our peers, and they could be our friends, and they're working jobs similar to ours, and just very normal people in our community. It's hard to hear them say, if they're able to talk, if they're not on a ventilator, a lot of them say, I didn't think that it would be me who's sitting in this bed. I thought it was either all political or all a hoax, or just people who are in poor health or maybe don't take care of themselves as well who are getting this sick. And they often show us texts of them telling their families to take this seriously, to get vaccinated, and to be really safe. It's hard, I think, to hear that all the time because it feels really unfair to these patients. We don't wish that on anyone, and we want accurate and consistent information to get out to the public. That being said, I think I can speak for all of my fellow nurses and other staff members that I work with that we can't do this alone, and we really are asking our friends and family and the whole community to do what they can to protect themselves, but also look out for their neighbors who maybe they're children, maybe they're elderly or immune compromised, and maybe they're not as lucky and healthy as a lot of us are. So that's all I have.
All right, question? Spokesman revealed.
I have a question on the federal contracted staff. How many of those staff members have arrived, and sort of what roles are they filling? I don't know if those are necessarily ICU nurses or more like support staff.
So any staff other than DOD? Have we had any arrivals other than DOD at this time?
Yes, so there were, the order was for, I believe, 111. They're still they're still working on fulfilling that order. Yesterday, the number I had was about 70 had arrived to date. It's a mix of registered nurses, and they have a variety of experience. And we also have medical assistants, nursing assistants, some respiratory therapists, and then some non-clinical workers as well that can go to do a variety of tasks. And just like everybody else, when you expand the capacity, you need more housekeepers and nutritional aides. So the hospital overall is stretched, so having the non-clinical is very helpful as well.
And what federal organization are they from?
Yeah, so the acronym is ACI. I don't know if I remember the name, but it's ACI Federal, and it's an agency that works with the federal government to do specifically this type of labor contracting related to disaster management.
Okay, so I have one.
Have things improved from the last time we had this briefing?
I didn't hear
So
have
a week
things
ago
improved?
we had a press conference. Have
Yeah.
things improved at all? And maybe it's important to talk about how we don't think we've seen the surge from the fair or school starting yet.
Some things have improved, some things haven't. I mean, we still have a large number of patients that we normally wouldn't have in the ICU. We have 30 or so COVID ICU patients, but we still have a busy non-COVID service. So last week we shut down. We were only doing emergency surgeries, and one of the things that does is that opens up room for other patients to come in, and we're able to take more patients. So, however, when you're putting off some urgent surgeries, things that need to get done like heart surgery, that can create more problems for you down the road. So this week we were able to do some of these urgent surgeries, and we're still trying to do those with the more resources that we have. So that I think has improved. But we still, in terms of the number of COVID patients, actually checked before I came out here. I think Joan said 105. We actually have 108. We have several patients that are teetering on the edge of needing mechanical ventilation. And I think that we haven't seen the effects of the county fair or the state fair that we had, and then school starting. We are not seeing very many pediatric patients at this point, but we know that usually it's a week or two before we begin to see a surge in patients in different populations.
Dr. Scoggins, to follow up with that, I mean, you kind of already mentioned it, but what kind of toll is that hospital capacity taking on those surgeries? And I know you mentioned you guys have started doing some more urgent surgeries. When is that going to be kind of back in full force?
Well, I don't know when it's going to be back on course. I mean, we pretty much do it on a daily basis. We make a decision on what our resources are available. Do we have an ICU bed? Do we have the right ICU nurse to do some of those like heart surgery and neurosurgery? And it can change overnight if we get a trauma in, if we get something, a very sick non-COVID medical patient. We're trying to help out as much as we can the critical access hospitals with taking care of critically ill patients that they've been trying to take care of with limited resources. So it's really a moving target. It never, I think that, we try to adapt as quickly as possible to the situation, and it changes hour by hour. And so every day is really a different day on what we can do.
What's your capacity looking like for pediatric beds?
Actually, do you know, Joan?
So right now, in order to make room for our adult COVID patients, we have moved our pediatric department onto our postpartum unit. And because those are larger rooms, we have been able to establish some double occupancy. And so what we're thinking is that we probably could do somewhere between like 8 to 12 at this point in time. But if we get a really significant pediatric surge, it probably won't be sufficient. So we are looking at other ways that we might be able to expand that further if needed.
Yeah. I would also say, one of the concerns that we have is the ability to take care of critically ill pediatric patients. I'm an adult critical care doctor. I don't do pediatric critical care. Emily is an adult ICU nurse. We don't have a PICU here. Our big concern is that as the cases rise in the pediatric population, there's very limited pediatric ICU beds in the region, and because kids usually don't get that sick. If we get a large number of kids sick at once, there will be a certain percentage of those kids that will need hospitalization, and then a certain percentage that will need ICU level care. So we've been training to do that. Several of us have taken pediatric advanced life support course in the last week and been certified in that. We were developing protocols to take care of critically ill patients in the hospital that we normally wouldn't take care of, to stabilize them and hopefully transfer. But our big concern is that that the regional pediatric ICU capability could be overwhelmed. and we'll have to take care of them here.
And Linda.
You mentioned the monoclonal antibody clinic and how that's been helping out. Is that only helping patients who've been admitted? Is that also able to help those who might be teetering on needing hospitals?
The EUA for the monoclonal antibodies is only an outpatient application. So we do give it into our outpatient clinic, and it's supposed to be given early in the disease course. And we have given some in our emergency room and sent those patients home. But it is not an inpatient approved treatment at this point.
Spokesman.
Do we expect that extra staffing support from the federal agency will help keeping it out of crisis standards of care, or is it still at this point patient volumes, like COVID patient volumes, really need to drop substantially before you'll be able to get out of crisis standards?
Well, there's several things that put us into crisis standards. Staffing was obviously the most painful part of it. And we have about 500 and some open positions. About 280 of those open positions are for clinical staff. And so even with the addition of the federal workers, we still need a fair amount of travelers as well as our own staff working overtime. So essentially what it has done is it has lifted some in terms of the overall burden, but that alone is not going to take us out of crisis standards. The number of patients has got to come down.
So one question we received from a reporter who was unable to make it was, we've been able to accept some transfers. Have we been able to transfer out much as of late?
Yeah, I don't have the exact numbers, but it's very few. We do look at, there's a system called WATRAC that we look at every few hours, and essentially there's only like a bed or so per day that shows up. So it's a pretty random event that you can get somebody out or somebody in, actually.
And Pam, so why?
My question is for Emily. What's the hardest thing a patient has said to you during this Delta wave that is still stuck with you?
And just make sure you talking to the mic. Yes.
Sure. The first thing that comes to mind is we had a patient who she didn't want to be put on the ventilator, and so at a certain point there was we'd kind of reached the ceiling as to what care we could give given her wishes. And so when the care team, Dr. Hoopman, one of our ICU doctors, had to tell her, you know, we really need to start looking at comfort care, making you comfortable. And I think she knew that was the reality, but obviously that's still really hard news to get. And she asked our nursing staff if she was too weak to write, but she wanted to write goodbye letters to her family of 25 people or so. And so one of my coworkers transcribed 25 letters to different family members and loved ones with her goodbyes and whatever notes she wanted to add. And that's, I guess, one example of something it's really hard for us to take on emotionally as we're putting ourselves in a patient like that, their shoes.
All right, any other questions? All right, well, thank you guys. Thank you. Perfect.
Welcome.
You okay?
Yeah.
All right.